Thanks very much, and it's an absolute pleasure to be here, and goes without saying, Vicky, it's a privilege and well deserved. So I'm going to change tack slightly. I'm going to talk more about the use of nanotechnologies for improving drug delivery. Just by means of an overview of my presentation, I'm going to give a very brief introduction. And then I'm going to talk about nanomedicines as they relate to parenteral delivery formats. Firstly, long-acting nanoformulations, which are beginning to emerge now across indications and are quite exciting. I also want to spend some time on nanocarrier approaches for targeted delivery and some of the benefits are being achieved there. And I'll also spend some time on oral delivery and talk about some of our work with antiretroviral nanomedicines for treatment of HIV. So in terms of drug delivery, there's a number of nanotechnologies which are being explored. Probably the simplest of them are solid drug nanoparticles. Lots of names for these. Some people call them nanocrystals, nanosuspensions, or nanodispersions. Equally, there's a number of ways in which these can be manufactured. Essentially, they consist of nanoparticles which are made of the drug itself. There are certain excipients in there, so typically you'd have a polymer, a surfactant stabilizer, but the nanoparticle itself is made entirely of the drug. These can be made either by precipitating the drug out of a solution to form a nanosuspension, or probably the most commercially successful approach has been by the smashing up of large fragments by nanomilling type approaches. So where you just take a big chunk of drug and you mill it until you've got particles of drug in suspension which are measurable within the nanometer range. So that's the most simple form of nanomedicine which is currently being investigated for drug delivery. Slightly more sophisticated than that, and we've heard about some of these already this afternoon, but the nanocarrier systems, they're very diverse in terms of their material composition. They range from lipid-based carriers like the liposomes that Vicky mentioned in her presentation, to micelles. There's also emulsions and solid lipid nanoparticles. These lipid-based materials have probably been the most commercially successful nanocarriers. There's a number of products which are already in clinical use based on the liposome technologies, for example. We've also got a huge diversity in the type of polymeric materials. So we've got cyclodextrins, for example. We've got dendrimer type materials, polymeric micelles, and emerging materials, polymer nanoprecipitates, which are looking particularly exciting in terms of targeted delivery. There's the inorganic carriers, which we've heard a lot about already today, which are probably less used for drug delivery applications, but are more relevant to the diagnostic applications. And then, of course, we've got various nanoparticles which are biological in nature, which are being used for medical applications, such as monoclonal antibodies or protein-type therapeutics, which in themselves are measurable within the nanometer scale. So, current applications for nanotechnology in medicine really rely on this fundamental knowledge of disease which has been accumulating over the last 100 years or so, and that's anatomical information, physiological, molecular information, which scientists are now really trying to capitalize on in order to exploit the opportunities with various nanotechnologies. That breaks down into a number of areas. There's a lot of diagnostic work being conducted. There's a lot of therapeutic work being conducted, but then there's this space in the middle where a number of investigators are focusing on theranostics, particularly in cancer, where they're aiming to deliver drug to the tumor, but also use the nanoparticles' unique optical properties to monitor the tumor growth or the diminishing size of the tumour. So they're therapeutic and diagnostic at the same time, hence their terminology is theranostic. Ultimately, of course, across these different applications, it's driven at earlier diagnosis, better disease monitoring, and important to say, I think, safer and more effective therapy. So I recognize this is a toxicology meeting, but I think it is important to recognize that the most important driver of nanotechnology in medicine is the improvement of safety of the existing therapeutics. Ultimately, of course, we're aiming for improved patient survival and reduced patient morbidity. So my talk centers around HIV therapy. I think it's important to lay some background on that. Demand for some preferred drugs in resource-limited settings now, which is where the burden of disease is for HIV, of course, is outstripping current manufacturing capacity. So we, as a species, aren't making enough drug to be able to treat everybody with HIV. And it follows, therefore, that any strategy that reduces the doses required for effective therapy are not only going to probably drive down costs, but they're also going to make existing drug supplies go further, meaning we can treat more patients with the existing supply. Back in 2014, the WHO statistics indicated that 2.6 million children are infected by HIV globally, with only 32% of them currently on therapy. So the pediatric issues in HIV that I'll touch on in a few slides are quite dramatic, and there's an urgent need for new formulations which are appropriate in pediatric populations, and I'll talk a bit about that as well. So there's other limitations of active pharmaceutical ingredients, particularly relevant in HIV therapy. Adherence is a major issue. I'll talk a bit about that and how nanotechnology is helping in that context. The drugs tend to be very poorly orally bioavailability. Many of them are cleared very rapidly through the cytochrome P450 system. There's huge inter-individual variability in drug exposure, which means you give the same dose to different patients, and they can range in terms of tens of thousands, by tens of thousands in terms of their plasma drug concentrations. Some drugs have fed-fasted variation, and various nanotechnologies are addressing that. And then, of course, we've got this huge issue of adverse drug reactions across the antiretrovirals, and these include off-target toxicities as well as some of the immune-mediated toxicities that came up in the discussion earlier. So I think it's fair to say that non-adherence to HIV medication is a major driver of drug failure. It's probably the most important one. And that has really spurred the development of these new long-acting antiretrovirals, which are starting to emerge. This is a pharmacokinetic profile. So this is a time in days. It's a once-daily regimen. This is the plasma concentration. So the patient takes the drug. It goes up, it hits Cmax, it's cleared, they take another dose of the drug, and they do that all the way up to steady state. And then, providing they take their medication on time, daily, they maintain their plasma concentrations within that therapeutic range within the plasma. Unfortunately, adherence is a major issue. So this graphic here lists down here just a small subset of patients where the bar chart here is green, the patient was taking their medication on time. Where the bar chart is red, it meant they missed a dose of their medication for an oral regimen. So this is a science in itself. There's lots of different patterns of non-adherence which occur. So you get some patients which are perfectly adherent. You can see it's all green. You get other patients where they skip the occasional dose. Some patients, like the guy up here, goes out every weekend, gets drunk, and then forgets to take his medication on the weekend. But this is a major driver of drug failure, because if you subtherapeutic plasma concentrations, then you're placing yourself at risk of the virus emerging resistance to the drug regimen that you're on. So just to show that diagrammatically, you can see a patient here that missed 3 doses of their drug, so they were dipping down below the therapeutic concentrations during that time. If they miss more doses, 5 doses, you get a cumulative effect, and they're spending most of their time subtherapeutic. And so what's emerging now is these, and what's of clear benefit, is the ability to give 1 dose of a drug and maintain your therapeutic exposure over a very long interval. And that's what we're talking about when we're talking about these long-acting nanoformulations, which are starting to emerge for HIV. So there's 2 drugs at the moment. One is being developed by Janssen, one by ViiV Healthcare. ViiV Healthcare being a collaboration between Pfizer and GSK. So you can see on the left here, rilpivirine LA is a drug where you give an intramuscular depot of solid drug nanoparticles, and you maintain the therapeutic exposure over a period of a month. So that's very exciting in terms of combating adherence issues and simplification of therapy. On the right here, we have another drug. It's now been called cabotegravir, and in this case, you give a single intramuscular depot of the solid drug nanoparticles, and you're able to maintain therapeutic exposure for up to 3 months. So very, very exciting. So we've got the data emerging from humans in a clinical sense showing the benefit for this, but in order to proliferate more research in this area, we really need to start to understand the pharmacology behind this and the mechanisms for the augmented exposure, which is there. There's actually a lot of gaps in knowledge. This is a grossly oversimplified cartoon of what's happening in the depot, and this summarizes what we know at the moment. We have the depot itself, which has the solid drug nanoparticles within it, but also the drug which is being released from those nanoparticles as the particles dissolve into a dissolved drug. We've got the blood capillaries running through the depot, we've got the muscle cells, and we've got the lymph capillaries, which also run through beneath the tissue. If we zoom in to the blood and lymph, we know the blood capillaries are surrounded by an epithelial layer, which is a continuous epithelium, so it has the tightest cell-to-cell junctions. The intercellular clefts in that are probably too small to let the nanoparticles go directly into the blood themselves. But the drug is dissolving, so it may be dissolving and then entering through the blood capillaries. We know that these cells, this epithelium is metabolically active, it's got drug metabolism enzymes, it's got drug transporter proteins, so they may be important in an effect through the blood capillaries. The lymph capillaries, which are shown down here, they're much bigger. The intercellular clefts, in a hydrated state at least, are up to 2 micrometers in terms of their width. So it's certainly possible that the nanoparticles could directly enter the lymph through those intercellular clefts, or again, those other mechanisms may come into play as I described for the blood capillaries. What we do know is that shortly after administration of the depot, you get a rapid infiltration of macrophages, and it's been shown that those macrophages can phagocytose the particles from the depot, and within a period of days, you get those macrophages differentiate into a granuloma around the depot, which again might restrict drug release, and therefore slow down the exposure to the drug. So many unanswered questions regarding the pharmacology of this type of depot, nonetheless a very exciting recent development in HIV. So I wanted to underscore the point that nanomedicine approaches are almost exclusively driven by a motivation to improve safety of existing drugs, and I got 2 examples of that. The first one is Doxil. It's a liposomal formulation. It's probably, or it's often termed the first nanomedicine. I think it was licensed in the mid-1990s. It's a liposome which contains doxorubicin dissolved at its core, and it capitalizes on an effect called the enhanced permeation and retention effect. So essentially, if you put a small molecule intravenously into the blood system, the small molecule will diffuse across the vasculature of healthy tissue as well as the tumor tissue. So you get penetration of the cytotoxic anti-cancer drug into healthy tissue and into the tumor where you want the drug to go. So by packaging up the drug within the liposome, you've now gone from a small molecule to a huge entity in a pharmacological sense. So bear in mind that a small molecule is typically around 1 nanometer in length, and Doxil, we've gone up now to 250, 300 nanometers. So you're actually talking, in a pharmacological sense, about a huge object. And so what happens is, when the nanoparticle goes past the healthy tissue, you don't get penetration into the healthy tissue, and you get an improvement in terms of alopecia, cardiotoxicity, etc. All the toxicities of the drug go down. When the nanoparticle comes across the tumor, however, it's able to permeate through the leaky vasculature surrounding the tumor, which is created as the tumor grows and stretches that vasculature around itself. Of course, things aren't perfect. Even though you've reduced cardiotox and alopecia, a new toxicity popped up with Doxil. It's called hand and foot PPE. It's probably driven by the altered distribution of the drug. Some people have speculated that maybe macrophage uptake and therefore distribution of the drugs to the hands and feet. But nonetheless, you've improved the risk-benefit ratio for Doxil, and that was a major driver for pushing Doxil through. The other example is ambisome. It's a liposomal formulation of amphotericin, and essentially amphotericin, as I'm sure many people know, works by intercalating into the membrane of the fungus. It disrupts the fungal membrane and kills the fungal cells. And if you use a small molecule of amphotericin, so you go intravenous with a small molecule, unfortunately what happens is, yes, the amphotericin intercalates into the fungal cell, but it also does it into the host cell, and so you get toxicity which emerges from that intercalation of the amphotericin into the human cell. So, if you take a liposome, which is essentially a lipid bilayer, and you're now delivering the amphotericin through the liposome, the oil phase within that liposome is chosen such that the affinity of the amphotericin for the liposome is lower than that for the fungal cell. So the amphotericin will come out of the liposome and intercalate into the fungal cell. But the affinity is higher for the liposome than it is for the human cell. So you get a reduction in toxicity of the amphotericin by delivery through the liposomal formulation. These are the early nanomedicines. Things are evolving now. People are using targeting approaches. They're using nanoparticles with antibodies on the surface to really augment these targeting approaches, which are capitalizing off physiological and anatomical features of the disease. So one thing that all current targeted approaches, be they passive or active, have in common is they require intravenous delivery, because that's the only way you can guarantee your nanoformulation is going to enter the systemic circulation. So one of the things that we've been trying to do in Liverpool is take nanocarrier materials, specifically lipid-based or polymeric materials, and see if we can deliver them into the systemic circulation via the oral route. The driver for that being that the oral route is still the most patient-preferred and simplest method for drug delivery. So we've been working on a new class of polymeric materials. They're called Hyperbranched Polydendrons. They're essentially polymer nanoprecipitates. They were invented in Liverpool by Professor Steve Ranod. So to cut a long story short, you end up with a nanoparticle consisting of polymer with various surface functionality. So you can have dendrons on the surface, or you could have a PEG surface, or you could have reactive groups on the surface which enable you to conjugate small molecules or aptamers or antibodies to the surface of the particle. In this example here, we generated a range of materials which have a combination of PEG or dendrimer on the surface of a material at different ratios. We looked at apparent permeability across a CACO2 cell monolayer for these types of materials. And you can see that by altering the dendron to PEG ratio of the material, we were able to drive more of that material across a CACO2 cell monolayer. This is with a probe. It was just with Nile red, just to get an easy readout. If you just incubate with a solution of Nile red, that's the apparent permeability you get across a monolayer. So all the materials were better, but we had this relationship with the dendron ratio. We've also got a couple of other materials, just similar polymer type materials with different surface functionality. And you can see that over here, again, apparent permeability across CACO2 cells, solution here with different materials. We can drive more of the particles across the monolayer. If we shut down ATP synthesis, so we shut down energy-dependent processes, we reduce this apparent transcellular permeability. So these are active processes. In addition to that, if we use inhibitors of endocytic processes within the cells, we can close down the transport for some materials, but not all of the materials. So we've got a combination of different mechanisms here for delivering of intact materials, at least across a monolayer. But clearly the situation is very different in the in vivo environment, as we heard from the previous speaker. Just to show this, though, I think it's quite interesting. If you look here at the co-nanoprecipitate and the pH-responsive material, the co-nanoprecipitate is better at getting across a monolayer of intestinal epithelium, but the pH-responsive gets us into macrophages. So we're currently playing with the surface chemistry around these molecules in order to try and get across the gut barrier and then into macrophages where we know a lot of HIV viral replication occurs. Solid drug nanoparticles have had lots of benefits for oral delivery. Here's just a few. This is Ritalin, taking Ritalin from a twice-daily regimen to a once-daily regimen through formulation of solid drug nanoparticles. A similar story with morphine, where you go from 2 doses down to 1 dose, therefore simplifying therapy. Here's an example with megestrol acetate, where a food effect was overcome by formulation of solid drug nanoparticles. And here we have a dose reduction, or not dose reduction, but an augmented exposure. So a nanoformulation versus a non-nanoformulation of dalfampridine. And you can see here that the AUC has gone up from 184 to 284. So a 75% increase in exposure to the drug. So what are the mechanisms behind this? And this is another grossly oversimplified model of the intestine, and we've heard a lot about this already. But we have the polarized intestinal epithelium cells here. We have the goblet cells secreting this mucus, which is essentially a network of glycoproteins over the top of the epithelium. We have the M cells, which are components of the immune system. A lot of people are surprised to find out that 70% of the human immune system is actually within the gut. And there's a number of components of that. We have the M cells, but we also have Peyer's patches, and we have an active lymph capillary network within the gut as well. So if you pop a solid drug nanoparticle or another nanoparticle type into the gut, first thing that will happen with a solid drug nanoparticle is you've got a much more rapid dissolution of the drug because you've massively changed the surface area to mass ratio. So the drug will dissolve faster, and that can saturate some of these efflux processes within the gut and drive the drug into the systemic circulation. We also know that surfaces are incredibly reactive, And because you've got a higher surface area of the mass, you've got a much higher reactive surface, and so you get a potential for reaction of the particle with the various surfaces in the intestine. We also know that those glycoproteins in that mucus have pore sizes within the 200 to 300 nanometer range, so they can get trapped in that mucus and therefore dissolve in the mucus, again saturating those active processes. There's some evidence for paracellular transport, although that's with different nanomaterial types. We got a route through the immune systems and the Peyer's patches through the M cells and these endocytic processes, and then we got an alternative route, particularly for lipid-based materials, which tend to go in through the lymphatics rather than through the hepatic portal vein and through the liver. So this is the last piece of my talk. I'm going to talk about some work we've been doing on antiretroviral solid drug nanoparticles for oral delivery. The approach generates nanosuspensions in one step. It's a bottom-up approach, so it's based on freeze drying or spray drying of emulsions. In simple terms, you form an emulsion of an immiscible oil in aqueous phase. You dissolve the excipients in the aqueous phase and the drug in the oil phase, and you form this emulsion. You then freeze dry it or spray dry it, and as the liquid comes out of that emulsion, you get local concentration of your organic into nanoparticulates. My colleague who invented this approach often terms it as a blueberry muffin. So you end up with a muffin which is made of the excipients with the blueberries of drugs stuck within that muffin. And that's this piece here, which looks like that under an SEM. And then when you reconstitute that blueberry muffin into water, the muffin dissolves and the blueberries of drug are released into a suspension. So this is good at covering a lot of ground very quickly. We can make a lot of formulations by freeze drying. For our clinical formulations, however, we have to translate from freeze drying to spray drying in order to establish scale to get to the doses needed in patients. So we're a multidisciplinary team. We're working across the pharmacology and chemistry departments in Liverpool. We're generating large libraries for the antiretroviral program. Just for context, we generated 4,500 different formulations, characterized 450 of them in terms of the pharmacology. This was done using this freeze drying approach. We're then doing a lot of physical characterization around those formulations. Then moving into the pharmacology, we're doing that in vitro library screening. Tends to be CACO2 cells, and we've got a triple culture system for that as well. We're doing a lot of in silico PK prediction using physiologically based PK modeling, and then moving from that in silico environment with the dose prediction it gives us into in vivo confirmation. And then at that point, when we've got a formulation we like, we translate it into spray dry to establish the scale. We're also working with partners for the clinical development, the regulatory approval, and also market analysis with a group in Geneva called the Medicine Patent Pool. And I think this is where we're up to now. Our first patient was dosed with our antiretroviral formulations in December 2015. We've been through all the regulatory and clinical protocol approval, so that's all sorted. I think these formulations have a particular benefit in pediatrics. This is a current pediatric formulation of lopinavir. It's actually a 42.4% alcohol by volume and 15.3% propylene glycol solution. So clearly not ideal. It's given to very young children. I mean, essentially given the medication in a shot of vodka. Sounds great to me, but I wouldn't give it to my 4-year-old. And I think this kind of demonstrates why we think this is important in a pediatric context. This isn't lopinavir. This is just an insoluble dye. So the top here is an unprocessed dye, You can see it does what you'd expect it to do. It doesn't wet. It's insoluble. It just forms a scummy mess on the surface of the water, and that is water. This, however, is a processed dye, so this is now in nanoparticulate form. You can already start to see it streaming down into the water. Now when you give it a shake, it's indistinguishable from if it were in solution. But it's not in solution. It's a dispersion of nanoparticles of the dye in water. We've done a load of immunological safety assessments on these materials as well. Getting back to what Vicky was saying about the immune system. We looked at T-cell proliferation. We've done this all in terms of non-nano versus nano for these drugs. We've looked at macrophage function. We've looked at cytokine release from CD4 and CD8 cells, T-cell surface activation markers. And we're really glad that we see nothing with any of the formulations. So it's great we didn't see anything. Not so great when you're giving a talk at a toxicology meeting, though, unfortunately. So our immunological assessments are now part of the European Nanomedicine Characterization Laboratory, which has just put out its first call for materials aimed at helping small to medium-sized enterprises translate their nanomaterials into clinical products. So this is my last slide. It's just an observation. We've got a lot of nanomedicine developing globally, and most of it is a technological push. So there's some really elegant materials chemistry being done, and it's about materials chemistry. And here's my material. It's great. Look, it's brilliant, and it's really clever stuff. But it's estimated that something like 80% of the materials in the literature aren't actually fit for their clinical purpose. So we need to try and find a way to better translate these materials. And I think it's fair to say what we really need is this clinical pull. So I think there's an unprecedented need for multidisciplinarity within the nanomedicine landscape. I just said that already. It's about different languages. So you've got the clinician over here saying drug resistance is a major problem exacerbated by a lack of adherence. And you've got the chemist saying, we're booming by. So we really need to find a way of improving communication between disciplines, I think. Just a blatant advert for the British Society for Nanomedicine and our new journal, Journal of Interdisciplinary Nanomedicine. And I'll finish with some acknowledgements, particularly Steve Renard, who's the materials wizard, Neil Liptrot, who's the immunological safety guy, Marco Siccardi, who's a whiz with the in silico modeling. And I'll leave it there. Thank you.
Questions for Andrew? Okay, I'll have to ask one then. So you started off with SDNs and said that there were currently 2 in development or in trial. Is that going to expand? I mean,
so for HIV, there's 2.
Yep.
The NIH in the US are putting a lot of money into it at the moment. We've just recently been involved in the creation of an R24 grant. It's a resource program to try and accelerate long-acting drug delivery. The big problem, of course, is there's only 2 drugs, and antiretroviral therapy is given as a 3-drug combination. So we haven't got a therapy yet, even though we've got 2 drugs. But solid drug nanoparticles for these long-acting formulations, they're already established for contraception, and they're already established in schizophrenia with drugs like olanzapine pamoate and paliperidone palmitate. So there are other long-acting formulations in other indications, but the HIV field is very excited by these new 2 formulations, and I expect to see more development in the near future.
Okay. Thanks a lot.
Okay.